Please tell us about your rationale for investigating renal denervation with RF ablation for the treatment of refractory hypertension.
Thank you. When we consider that for every 20 millimeter increase in the systolic blood pressure, there's a corresponding doubling of cardiovascular mortality, there's a strong rationale for the attention and treatment to blood pressure. However, for many patients who are hypertensive, and despite maximally dosed and typically numerous medications, these patients persistently have severe hypertension, posing them at greater risk not only for overall cardiovascular mortality, but for cerebrovascular mortality and renovascular morbidities, such as end-stage renal disease. And so the opportunity to treat patients effectively who have what has been termed uncontrolled or resistant hypertension despite optimal medical therapy provides a great opportunity for reducing not only blood pressure, but the adverse sequelae or consequences of hypertension alone. And historically, attention to the neurohormonal mechanisms and hypersympathetic drive had been largely unsuccessful with medical treatment alone. In the remote past, there was surgical sympathectomy as well that had adverse unexpected consequences. But most recently, the recognition that the renal nerves arborize or surround the renal arteries themselves provides an important opportunity for selective catheter-based renal denervation. And to date, as we'll discuss, these therapies have provided significant and clinically meaningful reductions in blood pressure over time.
And would you briefly tell us about the results of Simplicity Hypertension 1 and 2 trials?
To date, we're currently evaluating in the United States a large pivotal trial with renal denervation called the Simplicity Hypertension 3 study. But importantly, there were two predecessor trials. The first was the Hypertension 1 and the Hypertension 2 studies. The Hypertension 1 study was a single-arm observational composite of early phase and first-in-human experiences with this technology, for which we now have in a selected group of patients 3 years of follow-up. In addition to that, the first randomized trial was termed Hypertension 2, and this was a study of slightly more than 100 patients who were randomized initially to either control therapy or treatment with renal denervation. In both of these studies, these are patients with resistant or poorly controlled hypertension, despite best efforts with medical treatment alone. On average, these patients were treated with 5 medications for their blood pressure, and despite that, they all consistently had a systolic blood pressure that well exceeded 160. For both of these studies, Hypertension 1 and Hypertension 2, renal denervation was associated with a profound and highly significant decrease in systolic blood pressure as well as diastolic blood pressure. The average reduction in systolic blood pressure at 6 months, for instance, was approximately 30 points for both the Hypertension 1 and the Hypertension 2 trials. And importantly, in patients in the Hypertension 2 trial who were initially treated with control therapy, these patients too later crossed over to renal denervation, and they also derived a similar magnitude of benefit with regard to blood pressure decrease. In these studies to date, as I mentioned, we now have follow-up through 3 years with the Hypertension 1 trial and 1 year follow-up in the Hypertension 2 study, and these results were recently presented at the American College of Cardiology meeting and are also being presented here at the Angioplasty Summit. And in short, these studies show that for these patients who derive a marked reduction in their blood pressure with this novel therapy, that the benefits of this therapy are maintained now through 3 years of follow-up in the Hypertension 1 trial and through 1 year in the Hypertension 2 trial. And perhaps unexpectedly, there is an additional benefit that some individuals who were initially considered non-responders, who did not, for example, in the first month have a meaningful decrease in their blood pressure, over later term follow-up seem to benefit and seem to experience a reduction in blood pressure as well. The exact reasons and mechanisms for this are not quite clear, but it's quite a positive and welcomed finding.
Are there any side effects to these renal denervation therapy?
You raise a very important point. First of all, it's important to recognize that this procedure, at least to date in the context of clinical trials, and as far as we know in clinical practice in many other geographies, seems to be very effective, meaning that it is not only efficacious, but it is also very safe. There have been no, in the clinical trials at least, no reported device-related complications, such as trauma to the renal artery that's permanent. And in fact, over longer term follow-up, these patients have been followed with regard to electrolyte monitoring. Their sodium, their potassium all remain normal. There is no significant hypotension. The natural preservation of adrenaline and fight or flight reflexes seems to be maintained as well. And equally important, there seems to be no unexpected progression of renal artery narrowing or trauma to the renal artery. And finally, there also is a preservation of the kidney function. So there's no decline in kidney function. And we would hope that's the case given the reduction in blood pressure as well.
And also, could you briefly introduce the ongoing clinical trial, SIMPLICITY-3?
So the SIMPLICITY-3 Hypertension 3 study, as I implied, is a study that is a pivotal regulatory trial for approval in the United States. But it will also have the benefit of being the largest randomized trial evaluating this novel therapy, and it will therefore provide important insights and benefits in a broader group of patients. The trial is presently enrolling patients at approximately 90 centers in the United States. It's in the early phases of enrollment, so we have a lot of patients yet to treat, and hopefully successfully. But it's a study that is randomizing 530 patients in a 2-to-1 fashion to either control therapy, which is continued medical therapy, or renal denervation, very similar to the Hypertension 2 study. But this study also will allow patients who get randomized to control therapy to cross over at 6 months, providing they maintain their eligibility.
And there have been many efforts in extending the indications of renal denervation to the patient with sleep apnea or heart failure and chronic kidney disease. And would you explain to the audience how renal denervation works on sleep apnea and heart failure and chronic kidney disease?
I'll do my best. It's interesting that this therapy, as we have treated more patients, we learn as we go. And this therapy perhaps may mediate other disease conditions that some may be at least intuitively related to hypertension, but others may not. For example, what has been identified in the context of treating patients with diabetes, for instance, is that a select group of patients, but not all, who have diabetes and undergo renal denervation for the treatment of high blood pressure actually also have an improvement in glycemic control. And this may be driven in part by changes of sympathetic tone on muscle-related metabolism of glucose, but again, the exact mechanisms are not clear. Similarly, we know that there is a correlation with hypertension and obstructive sleep apnea. And to be sure, when patients have apneic episodes, their norepinephrine levels as well as their blood pressure considerably escalate. And perhaps by treating the somatic hypersympathetic state, that is the body hypersympathetic drive, this may in some ways improve sleep disturbances as well. And then there are other, and the mechanisms for that are not entirely clear. On the other hand, there are other benefits of renal denervation secondary to reducing blood pressure that seem a little bit more intuitive. One of them is related to diastolic heart failure, and there have been recent studies indicating that this treatment can effectively reduce left ventricular mass as a benefit of antihypertensive therapy, and it improves echocardiographic measures of diastolic heart function as well. And what's interesting is that the reduction in left ventricular mass seems to be disproportionately greater than what has been observed historically with medical treatment alone. And therefore, the benefit may be not only in reducing blood pressure and therefore reducing the heart workload, but it also may be driven by reduction in total body hypersympathetic tone. And there are finally other studies now that are beginning in Australia, New Zealand, and in Europe that are evaluating this therapy not in hypertensive patients but in normotensive patients who have advanced heart failure and left ventricular dysfunction. As we know well, the neurohormonal mechanisms of heart failure are associated with greater mortality and the need for transplantation and worsening heart failure conditions overall, and perhaps interruption of that through renal denervation may also benefit patients.
Thank you for your time.
Thank you.